Thanks for the introduction. Thank you to SAGES for the opportunity to present today, as well as the support of my colleagues and the Emory Surgery Department. I don't have any disclosures, but it is my birthday today. I thought you guys should know, because I have 7 seconds, and we obviously know each other very well now, so I will be accepting presents after my talk. Thank you. I'm not going to tell you how old I am, though. So I'm going to go over a brief outline, talking about background and enhanced recovery protocols, and then shift to describe our experience at Emory and implementing such a protocol in metabolic and bariatric surgery patients with a focus on implementation and adherence, followed by some conclusions. Most people know here what enhanced recovery means. These are really protocol-driven, standardized care pathways to help enhance the recovery of our surgical patients. They should be evidence-based, require a multidisciplinary team approach to execute, are usually associated with a lot of heavy patient and provider education and engagement, and need to be data-driven. So when you look at the history of ERPs, they actually emerged from fast-track surgery protocols that were initially described in the 1990s, pioneered in cardiac and colorectal surgery patients. And as these protocols matured into more modern enhanced recovery, didn't really show up in the bariatric literature until about a decade after these initial fast-track protocols. Fast forward a few years later, the first ERAS Society guidelines were published in bariatric surgery in 2016. And then about 5 years later, we've now started to amass meta-analyses in this space. And the general conclusions from these meta-analyses at this point, which are heavily focused on outcomes, is that while these protocols can significantly impact length of stay and postoperative nausea and vomiting, they tend to not have a positive impact on 30-day complications. This was an interesting study that actually looked at ERP implementation, which is a really important part of any of these protocols. So this was published by Stone and colleagues in 2018, and this study looked at barriers and facilitators to implementing enhanced recovery protocols in surgery patients, using an implementation framework to characterize these areas across 5 different domains. And one of the interesting parts about this study is that in the final analysis, only 10% of the articles actually addressed barriers and facilitators to ERP implementation, which highlights a big gap in our literature. And not surprisingly, some of the obstacles that they highlighted were things like lack of resources and poor frontline provider engagement. So I'm going to shift gears now and talk about our experience at Emory, where we piloted this work. It was focused here at our Midtown campus, which, if you know anything about Atlanta, we're kind of stuck in this 285 perimeter, so it's located in a very urban location. We do about 150 to 200 cases a year, so sort of a smaller middle volume. And really, even though there were barriers certainly to this protocol implementation, my talk is more going to focus on how we implemented and the importance of data collection. This is a quick snapshot of what our patient population looks like. For this particular study, it encompassed about 470 patients, and about 70% of our patients match the characteristics that you see on this slide. I would be remiss if I didn't thank and highlight the comprehensive MBS stakeholder team that we have. People from surgery to our coordinators to anesthesia, OR nursing, and certainly administrative support. We have a great team of providers that have helped us execute all of this work. So for our implementation process, this is a very busy slide showing you how we tracked our timeline for getting this work off the ground. We first convened here in August of 2019, which you can see with this blue star. We convened our multidisciplinary team and started to actually hash out our protocol. It took about 6 months to get that finalized. And in May of 2020, in the heart of our pandemic, we actually decided to move forward with launching our protocol and associated daily workflow checklist that I'll show you in a couple of slides. About a month later, we launched our virtual dashboard, which helped with data collection efforts. And then a full year later, we actually were able to get together our final updated postoperative order set that aligned with this newer version of our enhanced recovery protocol and checklist. This is just a snapshot of our protocol. This is the formal document that we put together. It encompasses a lot of details from the preoperative, intraoperative, and postoperative phases of care, along with all of our stakeholders involved. This is the checklist that we use that aligns with our protocol. It's an abridged version of it and is predominantly used by nursing staff during the index hospital stay, so that people have a reminder about all the different things that need to be executed, and it's a visual management system to help that. Also, depending on where you guys practice, I mean, I'm in an academic institution, so you need to think about who's putting your orders in for your patients. Over 95% of our orders are placed by surgical trainees, residents, and fellows, but they're not involved with all of this work usually. So instead, what we did is we created a centralized resource and guidelines, which you see a snapshot of that up on the screen, so that they could have some educational tools around these efforts, and more importantly, know their role and responsibility in putting the correct orders in. So prior to this particular study, we were doing elements of enhanced recovery to the best of our ability, but we really lacked the standardized protocol, checklist, and educational resources that I just showed you on the former slides. More importantly, we didn't have a tracking system in place. So we developed this virtual dashboard that you see here. And this is a snapshot of the first part of the dashboard. It displays data over a rolling 18-month period. This part shows volumes, OR times, and some of our outcomes. And the red line here kind of shows you when our protocol was officially launched in this timeline. So in our dashboard, we actually have the functionality to look into each phase of care, labeled here on the left side of the screen in black. And we can drill down into the individual elements shown here in red on the right side of the screen. And this section actually displays these run charts for monthly compliance in each of these areas. And what's cool is that surgeons and anesthesiologists all have access to this. They can log into this dashboard and filter at the provider level, and then they can look at compliance in these different phases and across different elements. So kind of drilling down, and I'm sorry, I'm going to try to go back if I can. So drilling down into measures. So after ERP implementation, we did see significant improvements in global compliance of all of these elements in each phase of care. But overall, as you can see here, based on the percentages, the numbers are actually quite low. It's hard to execute all of these elements because there's a sheer volume of them, and the fact that you need to have room for individualized care. Not all elements need to be done for each patient. So we have seen further improvements beyond the data that you see here, beyond this pilot study. And a lot of that has been matched to having this updated order set that reflects all of our updates to our protocol and our checklist. This here is a busy slide that kind of shows overall average monthly compliance pre and post ERP implementation across select elements in our phases of care. And the red boxes really highlight some of our wins, but also some of our disappointing areas. As you can see in the preoperative phase, we had significant improvements in heparin compliance. Intraoperatively, we've had significant increases in surgeon-done TAP blocks, as well as decreased intraoperative MME use. But unfortunately, postoperatively, we haven't been able to make a great impact on MME use, which is an area for improvement for us. So in conclusion, the ERP efforts for us have been quite successful. It's helped us monitor our compliance more closely, but also rallied everybody around standard work. And standard work is really thought of as the most efficient way to execute a process. So this has been really helped by having our providers and stakeholders engaged early and often in the process, both from implementation and creating the process to actually the entire protocol itself. One of my key take-home messages, and I'm a big proponent of measurement systems in general. We obsess about outcomes as surgeons, but we don't really know how we're doing with our process and processes measures, and that's a huge part of ERP implementation. So I would just advocate for us as a surgical community to shift the focus on process measures, because that's where you really figure out where you have areas for improvement for the future. And I hope that we can see more of this in the literature going forward. So I'd like to thank all my colleagues at Emory. They're not all here, but some are here, and want to thank them for all of their support in this work, and I'd be happy to take any questions.